All right, well, I have 103 and 30 seconds, so let's get started. Good afternoon, everyone. My name is Eileen Hupp. I'm President and CEO of the Palos Verdes Peninsula Chamber of Commerce, and I want to welcome you today to, this is the 5th of our weekly Zoom series, and we are very honored to have Dr. Lawrence Sher with us today. I'm going to introduce you to him in just a moment. I want to first thank the sponsor for the series and introduce him, Mr. Tony Self. He is the broker owner of Harcourt Hunter Mason Realty. In addition to being an awesome realtor, he is a terrific volunteer throughout the community. He volunteers with the Palos Verdes Peninsula Association of Realtors, with the City of Rancho Palos Verdes, and of course with the Chamber of Commerce. He and his wife Courtney are longtime chamber members. So I'm just going to turn it over to Tony for a few words on logistics and anything else you'd like to add, Tony.
Thank you, Eileen, for that kind introduction. So for those who've just joined us, please submit your questions down below. We have a send a question Q&A box for Zoom. We're not going to do anything through the chat. So if you do through the chat, just through the Q&A, that way we're able to track that. And what will happen, as Eileen will then ask the doctor your question, just to kind of keep the flow going. We find that's the quickest way rather than trying to unmute and mute and fumble around for that. So that's all I have to say. So I'm going to go ahead and turn over the show to Eileen.
Great. Thank you so much, Tony. Our format for today is obviously we're going to introduce Dr. Sher. He'll speak. We'll handle the questions, as many as we can, through the question feature, and anything that we don't get to, we'll send it over to Dr. Sher, and he can perhaps respond, or we can help him respond via email. We'll try to get to everybody as much as we can. As I mentioned earlier, we have 86 registered participants for this, so we're pretty close to our max accommodation, which is 100, so we're very excited to have such a good turnout today. Dr. Sher, we have a very broad cross-section of businesses on this call today. We have everything from schools, we have people from K through 12 and university, we have city officials, city staff, we have several hotels, restaurants, nonprofits, retail stores, we have a couple of hospitals on the phone with us, we have professional service people from insurance, marketing, we have banks with us, we have realtors, we have performing arts, we have senior living, the list goes on. I haven't hit everything, but I just want you to know that you've got a broad audience here, all different businesses, all different sectors, and certainly all different sizes. So with that, I'm going to turn it over to you. Let me briefly introduce Dr. Sher. He is board certified in both adult and pediatric asthma, allergy and immunology, and pediatrics. He is active in both the American Academy of Allergy, Asthma, and Immunology and the American College of Allergy, Asthma, and Immunology, and he is currently a member of its immunotherapy committee. I just lost his bio, it went off my screen. Anyway, be that as it may, he has been a member of the community, he's had his practice here at PV Medical Group for over 20 years. He also heads up Peninsula Research Associates, which does clinical trials and has had several medications approved by the FDA. He is a nationally renowned speaker, physician, and research professional. So with that, I'm going to turn it over to Dr. Sher. I'm sorry if I cut your bio off a little bit, but it disappeared off my screen. So good to have you here. Thank you.
Thank you, Ellen. Thank you, Tony. I always tell people bios are only when your mother is listening. That they like to hear, but it's not important on bios. But you know what's important is that I get to talk with the community, because the community is the most people you get to be with. And I've been up here for, I wish it was just only 20, it's 30 years now. And I have been able to be an integral part of this community in terms of being with the people all the time. And, you know, we're all in a unique situation. You said that this is a wide variety of people, but all of us right now are joined together with one common cause. And businesses are affected, our lives are affected, our lifestyles are affected. And this is most unique that none of us have ever seen, and all of a sudden the fiction books and movies have become nonfiction. And there's lots of questions. And so what I'm going to try to do, and I'm one that gives 3-hour lectures, and I told Jen, who helps with everything with me, that I'll cut it down 2 hours, and then she looked at me and said, "You got 30 minutes." So I'm going to keep it down to 30, because I really want lots of questions, and any question and every question is important. The longer I'm involved with COVID. And people say, why is an allergist? Well, an allergist is an immunologist. An immunologist is actually Dr. Fauci, one of his specialties is immunologist, infectious disease and immunologist specialist. And so when he's at our academy meetings, he's the one who speaks with us, and we are able to interface with him. Immunology is the one who works with this. But as the immunologist, and as I study and as I read all the papers, I'm starting to learn that we basically don't know anything about anything. And the virus has not told us everything or anything, if that's because every day I come to work and I'm more confused. So I'm going to try to go through, starting from history, all the way through what the virus is, to how we diagnose, or try to what the treatment is, which is what we're all doing, to the questions. And we're going to make this quick. So I'm not going to talk fast. I'm going to try to go through it in more of a brief manner. The history of it's short. The history of it just started officially December 31st, when the Chinese officials at least declared this internationally, that there's something going on within the community. In January 7th, the outbreak was called finally COVID-19 because it was related to the coronavirus. So it was coronavirus 2019 because it started in 2019. There it started to go quickly. And I'm looking down at my notes on this one because that's the only notes that I really have, because there's so much that exploded. February 4th, we started to hear from January, not a lot happened. We started to see restrictions because it really was in China. And then in February, it started to travel about the cruise ship. In February, we heard China all of a sudden had a death toll of 811. Going to the end of February, we heard, and then we found out later, we'll talk about, that the first death was in the United States in Washington. If I jump to it, and I actually have many dates in between this, March 10th, Italy announced that they're locking down. Okay, we all of a sudden got more involved in this as we heard from our school districts. It started as we heard death rates. Our school district, I think it was March 13th at 9 o'clock at night, it came across our email about our 14-year-old that school's canceled that Thursday night. More, March 15th, 29 states, March 13th to 15th, 29 states closed all of their schools. March 16th, we started to get our shutdown orders throughout all the states. March 16th, we had a vaccine that came across. Going to March 20th, cases in California, remember this is only April 23rd, cases in California exceeded 1,000. Okay, that's it. 1,000 was a week ago. Okay, I'm going to give you the value soon where we're at now, but just think about it. 1 month ago was 1,000 cases in California. And now, you know, we're going all the way up as we see it now traveling to every single country to today, okay, from China with those 800 cases that were reported to us in January to now nationwide or country worldwide, 2,658,000 deaths as of yesterday, or infected, 2,658,000 deaths, 185,000 deaths. Now let's go home to the United States. From that first 1,000 a month ago, we now have reported 805,000, that's as of 2 days ago, deaths, 46,000 deaths confirmed in 1 month. This is not to scare people. This is just what we know. It's common knowledge. It's there. It's fast growing. We know about it. We're going to talk about treatment, and treatment, not maybe so true treatments that everybody talks about, but this is here. How long it's going to stay, because people always ask that question. I give that same look as I give my children. I don't know. And nobody knows. Nobody, you know, we talk about the peak, the flattening. We don't talk again if it's going to peak again. And so we just know data. And this data is probably underestimated. And so we just know what's happening at this point in time. Let's go over the virus. okay? Because all of a sudden we're hearing about coronaviruses and we think, oh, all this coronavirus is big. Remember, SARS, okay, which we heard about in the early 2000s, that we thought was going to be a horrible pandemic, really never hit us. Okay, severe adult respiratory syndrome. That was the early 2000s. And then another type of coronavirus, MERS, which is Middle Eastern respiratory syndrome. And now we have our COVID, which is, the true name of it is SARS-CoV-2, because it's very similar to the one in 2001, 2002. But what happens with it is it's just much more infective because it doesn't go as deep into the lungs, but it causes very similar problems. And so it's called SARS-CoV-2 is the name of the virus. Just like we have with AIDS, AIDS is the name, and HIV is the name of the virus. We have COVID-19 is the name of the disease, and the virus is SARS-CoV-2. So that's what you're going to hear about the names. Now, common cold. We have actually 4 coronaviruses that cause the common cold. Now, we're going to get back to it in symptoms, but the number one symptom that the coronavirus common cold cause is lack of smell and lack of taste. And so that's where we get back to the questions I always ask patients. Do you have smell and do you have taste, or did you lose it when you actually get the COVID-19? So you get coronavirus every year, and we test for it every year. It's just not the true one that we think of right now. So it's been around. Mutation-wise, that's another fact versus fiction. Everyone's talking about that this virus is going to mutate, 1,000 times. This actually is a stable virus, not lots of mutations. The SARS virus in 2001, 2002 actually did mutate a lot. This one's fairly stable. So as we help develop vaccines, that one is going to be maybe easier. We're working with a few companies right now, so hopefully we'll be one of the sites that will be working on vaccines. So us as a community will have the opportunity to be working with the vaccines as a whole, because what we do here at Peninsula Research is really the South Bay community. So we'll hopefully have the vaccine as we're working with it for the phase 2 and phase 3. So we'll know about that within the next few weeks to next few months. Now, let's start to go back now to 19. And what do we see? We're going back to the full evolution, and the evolution of COVID-19 are 4-month evolution. So, I don't get to talk about the past 100 years. I get to talk about the past 4 months. We used to tell people, okay, do you cough? Do you have problems breathing? Okay, do you have chest pain? And do you have fever? That's all we had to, and then we had to worry about, did you travel to, we used to talk about traveling to China, Korea, Iran, and to, Italy. That's it. And if you traveled and you had those symptoms, we would test you. And then all of a sudden, we found out it's exploding all over the place. But what was interesting is we started to find out other symptoms. And fever, yes, occurs up to 99% of the time, but now we're finding more that may not have fever. And the fever was just a low-grade fever, 100.4, and now we're finding out that some people, it's no higher than 99. And what's interesting is you're finding some people who actually have a decreased fever of 95 or 96. And so you're getting both sides. But initially, everybody had a fever of 100.4, so we thought. But now that we have these millions of cases, we're getting more data coming across. Fatigue, extreme tiredness, dry cough, not wanting to eat, sore muscles, okay? Well, what do these all sound like? They also sound like the everyday bad flu. Same thing that people come in with. Sputum production, hard to breathe. But now you're talking about smell and taste, so we're getting a little bit different. Now what's coming up we didn't see initially was abdominal pain. I have somebody whose son is back east and he just got to the ER. He has severe abdominal pain and his blood tests are elevated. Well, it's typical blood tests that could be COVID-19, so I told them test right away. So that's something we now have to think about, is the abdominal pain. The newest one that's come out over the past couple of weeks is changes in color of the fingers or the toes, the end part of the digits. And that could be your first presenting signs. So we now have to look at that. So each time, we don't know a lot about nothing. That's what I keep telling people, because we have to always be cognizant. But at the same time, we can't think everything is COVID. Doctors have to be, looking at everything else. We got to keep thinking. Influenza basically is gone. May 1st is the last official day of influenza season. We really haven't seen influenza in about 6 to 8 weeks. But, we still have to think of other problems. We can't forget and think COVID. And that's why we need to look at the patient. We need to really tell them what's going on. We can't keep that hands off and take a good history. We have to really look at that. I usually, when I get to talk face to face, I get to say, do you have any questions? But we're going to postpone the questions to the end of the talk. So we've gone through the history. We've gone through the virus. We've gone through the signs and symptoms and how people come to us. Now let's go through the diagnosis, and then I'm going to try to go through what people come to and tell me. There's not a lot of ways of diagnosis. There's people who come to the hospital and they have elevated blood tests. They have lots of problems, but 50% of cases are asymptomatic. I'm not sure what to do with asymptomatic, because we hear lots of people talk about asymptomatic and viral spread, and people are getting sick because of asymptomatic. But we have about 5% knowledge of whether that's true or not true. Okay. Now, after that 50%, you have the 50% who are symptomatic, but only about 20% of that 50% becomes severe. Moderate is about 30%, and 50%, okay, the rest are really mild. Mild are the people who have loss of taste and smell, have a severe headache, which I've mentioned before, and it's a severe headache. They may have the dry cough, but they don't get the respiratory distress. The moderate get the respiratory distress, where it feels a little harder to breathe, and they get the bad dry cough. Severe is where you see their oxygen content go down. And every patient is different how it happens. It may start 3 days later. It may start 7 days later. After 14 days, you usually don't see that start. But they may get mild symptoms, a little bit of a break, and then severe symptoms. Depends upon the individual. Now, at home, if they're not that sick and you see COVID-like, the CDC has changed it from those who traveled and those who were super sick or had contact with a healthcare professional, to now we have people who are 3 priorities, okay, from contact with people with COVID to healthcare professionals to people with symptoms on priority. And within those priorities, we can do nasal swabs if they're sick. And those are called polymerase chain reactions. And that's actually looking at the RNA particles and finding if it's there. The problem with PCRs is you get a lot of false negatives, meaning if I can catch you between day 1 and day 6, it's a phenomenal test. And if I can get that swab inside your nose to the back of your throat, it's phenomenal. And I have staff that does it perfectly, because they do a lot of them, okay, because you do it for whooping cough and all sorts of other problems. However, if I don't do it right, I'm not going to get a good swab. If I do it between that time period, it's 90% or greater sensitivity. If I do it too early or too late, it goes down to less than 50% accuracy. So I have to really do it the right way, or else it's negative. So if you have classic signs and symptoms, what do you tell people to do? It's a negative test. What do you still tell people to do? Isolate. Stay home, of course. Wear your mask. And if you have lots of family member, sit in your bedroom if it's classic signs and symptoms. Now everybody, because is talking about the blood test, the antibody test. The antibody test is supposed to cure everything in the country because the antibody test is going to allow everybody to go back to work, everybody to go to the beach, everybody to go to the parks. That's supposed to be the cure-all and get us all going again. No. I'm going to tell you right here, no. Because although it's very sensitive, okay, meaning there's not a lot of false negatives, although it's very positive, it's very specific, means there's not a lot of false positive, we're not quite sure what to do with it. Because the antibodies it makes, whether it's the early antibodies called IgM, or it's the late antibodies called IgG, we're not quite sure they're protective antibodies. In other words, people may get it more than once, COVID, and we're finding reports. I even found one here at the office where they had a positive nasal swab. The nasal swab became negative. Then they got sick again, had a positive nasal swab. And then we did a blood test, and the blood test showed that they had early antibodies. And so we're not quite sure what they had. Two infections is our hypothesis. And so that could happen. So even if you had positive antibodies, it doesn't say you can go back to work. You have to look at that. So the serology test could only be so good. The next question with the serology test that everyone asks, are they FDA approved? And that's an important question. None of them are FDA approved. Right now, the FDA is going through and giving what's called EUA, Emergency Utilization Approval. So each company has to turn in a battery of tests. Okay, remember this is 4 months old. So companies had the past 3 months to test around the world, okay, positive samples, negative samples to be able to get sensitivity, specificity, okay, to be able to say false positives, false negatives, true positives, true negatives, compared with all the different serums from all the different patients. You have to turn in several hundred patients. You also have to turn in, is there cross-reactivity with those other coronaviruses? Because if there's cross-reactivity, well, everybody's had these colds with other coronaviruses. You have to pick up to see if there's cross-reactivity with the animal coronaviruses, which are SARS, MERS, and now their own. And you have to pick up, is there cross-reactivity with H1N1, the one we all know about so well, and other influenza A's and B's, and any other type of common virus that we know. So you have to turn that in. 19 companies turned it in, and the FDA goes through all of them. If you're able to get all that data, then you can say it's a good test. So you want to make sure your doctor, no matter what test they do, has all that data available, whether it's EUA or not. USC, which is doing its study right now, initially started on a non-EUA test because they couldn't get it. The test I use is non-EUA initially because we couldn't get all the tests we needed to be able to test. But all of us, USC and ourselves, which often work together, UCLA and ourselves, because I do the research, we all look and have data of, I have 2,000 patient data put together of looking at sensitivity, specificity, and cross-reactivity, because it's necessary, or else don't use it. Because then if you're below 90 to 95%, it's not a worthwhile test. And that's what you need. And so those of us who do the research get the advantage of getting the data. Important is to be able to get the data. And so that's why we look at it in that way. So if we're going to have this, okay, you have to be able to know how to deal with it. And you have to be able to say, what can we do? Well, as a physician, am I going to change any way of my treatment with the patients? No, it doesn't change my treatment with patients if I have positive results. It's going to be able to tell the patient that what they had. Now, that brings up the story that patients say in December, I had severe headaches that lasted for a week to 2 weeks. In January, I had that, or February, I had that. No smell, no taste, fevers, and I have never been slammed like that in my whole life. I feel it had to be COVID. Was it? And so that's the type of patient who often wants to get the antibody testing because they want to make sure. but making sure doesn't necessarily do anything. And that's what I tell all the patients before they get antibody testing. It's important to realize that. It's not going to change decisions. There is a test called ELISA testing, which may tell you whether it's neutralizing or not. That's a much more complicated testing that we do, that we also use to verify whether a test is sensitive or specific when we do all of our testing. But it's much more complicated, but that's what helps tell us false positives and true positives in terms of the tests that we use, but we don't do those on a routine basis. So we use those just to test. When we do our vaccine studies in the next several months, the companies that we do vaccine studies to make sure that the antibodies are useful to protect us as a whole, because vaccines are going to be our ultimate protection. We use ELISA studies because those are the neutralizing antibodies that we're able to make. But for all of us who got sick several months ago, now they're telling us that we really didn't have the COVID-19 until March-ish. Well, now we just found out from Santa Clara County that a patient from February 3rd, 2nd or 3rd, I forget which date, was probably passed away of COVID-19, did not travel. If that patient truly passed away of COVID-19, which the medical examiner says definitely was, probably caught it at the beginning of January. So what sizing is, it probably was in Northern California, if not in Southern California as well, in December, January period of time. There's two strains. There's an S and an L strain. S strain was less severe than the L strain. So maybe we had the S strain and then, L strain started to come over a little bit later. Hypothesis, we don't know, we have no idea about this. And so it's really, really important about it. Now, what's our current treatment of choice? Well, it's what we're all doing, we need to continue doing. It's social distancing. So we need to make sure that, if we're outside and we have to go outside, we wear a mask. And wearing a mask protects everyone else from us. We need to wash our hands. I wash my hands 80 times a day because of patients. So I put cream on a lot, or else I get real dry. But washing your hands actually is better than gloves, believe it or not. Because if you're washing your hands constantly and washing your hands in between your fingers and all your digits, then you're really getting clean. And so washing them for a good 30 seconds to a minute is what you want to do with a good soap. That's what you need to do. But social distancing is still what we need to do. And we need to push that. And we need to pursue that all the time. I'm actually, on a personal note, worried about this weekend. It's going to be 80 people are going to be outside. Let's hope people still practice a lot of the social distancing measures that here in California, at least, we're being so smart and urging to use. Medication-wise, are we seeing much success with medication? Well, remdesivir, which was a anti-RNA nucleic acid, which cuts it basically, the latest report just came out that it failed its primary endpoint. So that we don't have. The hydroxychloroquine, one of the reports that just came out didn't show that much of a benefit, has its toxicity. We just turned down a study that was going to be looking at it for one of the companies trying to do a double blind. So they may be going through with that. But right now, the French studies don't look like they included all the people. So we're not quite sure if that's going to be something. There's a company we just talked to yesterday that actually has some promising treatment right now until we come up with the vaccine that may come out in September. So we have, promising prospects coming up sooner rather than later. But remember, December 31st. So to get this far quickly is pretty nice. So we've come real far. I think I got my allotted time of, I could tell Jen, this has been, I can't see my time period. I did it within a half an hour. So I want as many questions as people can ask. So please.
All right. So thank you so much. And you can talk you've got a little bit more time, but I will tell you, we've got like 25 questions. Okay, which is crazy. So we're going to try to go through them as quickly as we can here. Thank you so much. This has been fascinating. And again, Dr. Sher is right here, is on the third level of the promenade with both Palos Verdes Medical Group and Peninsula Research Associates, and a longtime chamber member. So thank you. So first question, please explain how an increase in COVID-19 testing will inform when businesses will be allowed to reopen. How can a test which is diagnostic in nature and therefore only indicates whether or not a person has the disease at a single point in time give us any actionable information?
Well, if you listen, good question, great question, with no answer.
Yeah.
But if you listen to the scientists like Dr. Fauci, they're saying it will give us epidemiologic evidence of who has or who doesn't, potentially. At this point in time, with the testing we have, it doesn't necessarily tell us when we can return or not. That's the problem we have. We can see flattening of the curve. We can see who's, having actual disease, who's not going to the hospital, who's not going to the doctor's offices as much. So by history, we can get better results and see the flattening of the curve. By the blood tests and the serologic tests, no matter which one is used, we're not going to necessarily make judgments. The problem is in California, we're going to see 10% of the people that are truly had antibodies to COVID, to coronavirus. And so we're not, excuse me, we're not going to see that at this point in time. And so that means 90% have not. So that's where we're a little bit worried about. If you do antibody screening across the board, across the country right now, we're getting about a 3 to 5% positivity rate across the country. So in other words, your answer to your question is it doesn't.
Okay.
And so that's what worries us all.
Got it. Thank you for that. What are, if someone was sick, this is a question from a chamber member, if she was sick this past January, with what she believes were COVID-19 symptoms and has an underlying health condition, should she come in and be tested for the antibodies? And, I know it's hard because you don't know the patient, but just a general question.
I think, knowing the high risk factors such as, diabetes, hypertension, being overweight, asthma is not a high risk factor, but COPD is, immunodeficiency. It's worth getting it, but it's not necessarily telling you anything. And so if you're high risk, you need to make sure you social distance, even if the antibody's positive. But it's enough to say, okay, get it so you know you've had it, but it's still saying you need to social distance.
Okay, here's a question from someone who works at an essential business that's open right now, happens to be on the food service grocery industry, and this person's daughter has some severe underlying health conditions. Should the mom be concerned? Or maybe it's the dad, I don't know. Should the parent be concerned?
No, I heard today or yesterday, everybody was recommended in the essential industries, especially the food industry, to be tested. That was just passed down yesterday, I heard. It was either yesterday or this morning that was passed down. Should you be concerned? We're all concerned with that. I have a son who's immunodeficient because of kidney transplant. He's older. Unfortunately, I haven't been able to see him during all this time. But he's immunodeficient with medication. If your child is higher risk, you just got to make sure you wear a mask around your child, is what I would say.
Thank you. You may have addressed this, but let me just go back to this. Is the antibody testing being done by Palos Verdes Medical Group part of a broader research study? Just if you could comment on that.
It's not part of a research study, but because my mind always thinks collection of data, you better believe we already have about 750 patients. We want to put the data together to be able to say in the South Bay area, the sensitivity of the testing or specificity of the testing. And in the South Bay area, we're 3% positive or we're 5% positive. or, patients who have, because we ask questions, we do a telephone consult, and we ask questions. This is the people who are more positive. Everything is HIPAA compliant, so nobody's names is there or anything. But it's important that people know what's really out there, and it's important that it's information that's released, so we know. So everybody else in the area can be able to feel comfortable and know how to do things.
Okay, thank you. You touched on this, but let's come back because a couple of people have asked it. How accurate are the existing antibody tests?
The existing antibody tests across the board, the 4 that have been given EUA, ours, and a couple others, have what we call specificity, which means false negative rate of about 97 to 98%, sensitivity, which means a false positive rate of about 96%. So they're highly, very good. Overall, if you look at all the data over the 3 to 4 months of these being done, they're greater than 90%. Now, people go and do rapid streps all the time, and those are about 86 to 87%. Your rapid flus that people go to the office all the time are about 87 to 88%. And so these are much higher right now. Now, we have 3 months experience with them, so I can't tell you after doing 1 million patients what's it's going to end up being. So right now, acutely, over the past 3 months of people testing and doing them, this is what we have.
Thank you. That's great. If someone decides, here's a question from a member, if I decide to have antibody testing done, and I don't avail myself of Palos Verdes Medical Group, which I would recommend you do, what should I ask or look for to help determine if the test is more likely to be reliable? What information should I be asking the tester about?
Well, when you ask for, I'm very much, everyone wants to say, is this FDA approved? Never ask FDA approved. Ask if you have the data that tells you sensitivity, specificity, and cross-reactivity.
Okay.
You want to know that that person doing the testing knows that data. You just don't want them to know, this is a test that I was able to get. No, you want them to know data. And so ask them specifically, do you have the data about sensitivity, specificity, cross-reactivity? The other that I didn't mention is variability. They make many lots. So each batch to batch, are they almost 100% identical? It's like we have positive controls. So I have serum we know is positive patients. And so we test each different batch with positive control to make sure that they're positive. That a positive is always going to be a positive. So we take samples out because I want to know that there's no variability between batches.
Thank you.
No.
What are the recommended guidelines for households where every tested positive for COVID-19? Is there concern, or should we be concerned about re-exposure and passing it back and forth amongst the household once again?
We don't know.
Okay.
Once the basic rules are, and this is where we're getting confused. Basic rules are, once you're clear, 3 days later you can go out. But now that we're doing lots of PCR testing, redoing nasal swabs, so not where we are, we're finding some people may carry virus for 4 to 6 weeks. We're finding out that some of these people who carry virus maybe never made antibody. So we do antibodies, the 15-minute finger prick, and we find out they never had antibody. Or they never had the immediate antibody, the IgM. So we're finding out all sorts of things as we keep going. And that's why I collect the data to really compare on some of these patients to see what happens, because this is going to give us more information on what to tell patients. So the next time you have me talk, if you ever have me
love it.
again, I'll be able to give more information, because information is what is gold. So that's what we're getting, because as you read more and more literature, doctors to be able to make decisions.
Yeah.
And so it's so good. But we're not quite sure. But I have families who everybody had. I just had one family of 4 children. The mom and the dad had it except the dad. He's gloating. But everybody had it except one. And so they stayed in for 4 weeks.
Wow, thank you. And by the way, we would love to have you back. Based on the interest and the number of questions that keep going, love to have you back. I'm not sure, Dr. Sher, I understand this question, so let me try to read it and hopefully it'll make sense. Why was the United States not treated as a World Health Organization protocol? I'm not sure I know what this person is getting at here.
I think there's a political question about that.
Okay.
Basically, why did we not? There was some questions, and so there's some political that I'm not quite sure I understand, but there was something within there. What rules we followed or didn't follow.
Got it. Okay, we'll pass on that one. Thank you, though. Thoughts for, okay, I'm going to try to pronounce this. Thoughts on, I think you may have touched on this as well. Thoughts on remdesivir, Z-Pak-hydroxychloroquine. Do other meds accompany remdesivir for the treatment? And then also, any thoughts on supplements, both preventative or if you are diagnosed with COVID-19?
Oh,
Thank you.
Supplement is zinc. Does zinc do anything?
Yeah.
Zinc is pretty good to take because it doesn't hurt, but there's never been anything proven. The biggest three mix that was talked about for a while was Zithromax, a Z-Pak, hydroxychloroquine, and let's see, it was a Z-Pak, and then aclitamide was added, which was an inhaler, and then there was also, it wasn't remdesivir, there was hydroxychloroquine, Z-Pak, zinc was added to it, and then the other one was, the flu medication, Tamiflu. Well, we've never tested all three alone. Hydroxychloroquine, I don't think it's going to work. Some people say it stops cytokine and the cytokine storm. It's never been proven. It does not, I know personally it does not stop the cytokine storm, which is IL-6. Remdesivir, I think, is on its way out. Big stock market crash on that today with the drug company because it didn't show anything. And Tamiflu doesn't even do anything to flu other than shorten the course. So it's not cidal, we call it bactericidal or virucidal. It's static, meaning it slows it down a little bit by a few days. So we give a lot of it, but it doesn't do a lot unless you get very early on, the first 24 hours of the flu. So we don't have anything at this point. One company is developing antibodies that block it, so it could be used preventatively. They're going to first study it in healthcare professionals' emergency rooms. If they give it, they've not had the disease. Shot every 2 weeks of an antibody that'll block the SARS-CoV-2, so that they'll do that. And that study is going to be starting full blast in July. A very well-known company will be doing that I talked to yesterday.
Good. We'll wait to hear more about that. That's great. Okay. Hey, this of our members who owns a retail business, and her question, which I think we're all would love to know the answer to, is what do you recommend that businesses do to sanitize and prepare for reopening?
Well, it's interesting that everything works to kill, bleach, everything other than chlorhexidine. Chlorhexidine is the only agent that does not kill the SARS-CoV-2. So bleach, getting rid of everything and cleaning and scrubbing down will help get rid of it. And then every day cleaning down everything. In our office, which we still see patients without problems because we have a well room and a sick room and waiting rooms. And then I have exam rooms that are sick and exam rooms that are for well. So because we see lots of different types of patients, we scrub each room afterwards and we use substances that are bleach-like to clean it down each time, and all of our desks and everything. And we just do it every half an hour. In retail businesses, you'll do similar at the desks when they check out or, buy, and then all around you'll just be doing. You'll also leave space so people can socially distance themselves.
Okay.
And have it in different ways of going around in circles or whichever way. It's going to be a whole new world. So we're going to arrange our stores, and the best way to do things is to be thinking about it now. How can you arrange your retail space to have social distancing the best, rather than people who used to just intermingle with each other? How can you do it and arrange it so people flow in a different pattern? If you arrange ahead of time, it may work really well, and you're ahead of the curve.
Yes.
Is what
Thank
you
you for
really
that.
wanna do.
Thank you for that. And I just, the chamber is actually starting work on a blueprint for that to help our businesses. So thank you for that. And we'll probably be cycling back to you with some more questions on that. Question, I'm one of your allergy patients. Which autoimmune diseases are considered an underlying condition?
Well, that's a great question. It's basically anybody who's immunodeficient. So it's not so much autoimmune like, thyroiditis or any of those type of autoimmune diseases. It's if they're immune deficient. So if their T cells, B cells, all of those, their IgG is low, all of those. So immune diseases are not, but those lead to people being sicker. If you're sicker and you're weaker, you may have a higher chance of problems.
Thank you. Okay, here's a good question. All right, when you touched on this earlier, but there's a second part that's just great. This comes from one of our someone in the education field. Dr. Sher, who indeed is at most risk? Since we're seeing people get reinfected, this is his question, do you think the herd immunity idea applies? And how realistic, in your opinion, is it that schools will be able to reopen by the fall? Not to put you on the spot.
A 14-year-old asks that all the time.
Yeah.
Okay, let me give you a doctor answer and let me give you a public answer. The doctor answer says, I don't think it's realistic. I'm going to be more conservative. I think any area that's great, where you have lots of people in a small area, is at more risk. That's my opinion. That's an opinion. And to be honest with you, I think this is a physician answer who should go to Dr. Fauci et al. I mean, I think the man is brilliant. I think his group of people that he's working with are going to give us the answers. And I do lots of reading and I do lots of listening. And when they finally say, this is how we need to do it, that's going to be the best answer. I don't want to hear and then this is probably wrong to say, it's not a political disease. It should be these people like Dr. Fauci, because they really know stuff. I know him, I've seen him, I've heard him lecture, it's amazing. So I don't know the answer, but my fear is if you look at history of severe pandemics, they do have different spikes. And the different spikes are, we're all going crazy. We want to get out. It's going to be again, the ocean that's behind you is going to look exactly like that, because we don't have smog right now. And so it's going to look exactly like that this weekend. And so we have to watch out. And so we're going to have a spike again. And I think that's why people are so curious about the antibody testing. I mean, we've done, believe it or not, from Friday, and I have scheduled through Wednesday, 750 tests. And people really want them. They're going to our website and they're emailing us, and the website, is just there. Everybody knows. And they just go on it and they want the test badly. And we talk with them, and there's a lot of anxiety out there. And to be honest with you, if we're helping anxiety, that's a big thing, because as physicians, we have to think about anxiety and depression and just what people are feeling. It's not just science. It's still the first day of medical school. That first think about the patient and talk to them. Right now, I think we need to talk and handle that too. That's as important. So the school question, I came about a long-winded roundabout, but the answer is I don't know. But we do have to handle the patient.
No, thank you for that. Very important. Well said. Question: can you comment on the impact, if we know what it is, on high heat, high humidity, as well as, do you think we'll see a spike again in the fall?
Well, what the fear is, and I think that's what that CDC gentleman, the head of the CDC, had to back off his answer. But his fear is in the fall, October, November time period, is with influenza plus coronavirus. And is there going to be a confusion? and how to handle that, because we obviously won't have a vaccine. We may have somewhat of a treatment, but not much. And so what are we going to do with that? So we will, in my estimate, not that we may, but I fear we will have and that's why the question for education, what are we going to do, is important. And I think they have to think through that very carefully, because we have to deal with the sociologic aspect of school. We have to deal with stopping school again. We have to deal with having a spike. It's so hard of a, concern. Lots of stuff, let alone the economic picture. That's a whole other issue that all of us, I mean, everybody on this call, this Zoom conference, is thinking and experiencing. There's so much.
Yeah, no, absolutely.
But I'm worried about a second spike, if not third.
Oh, interesting. Okay. All right. Question, if you have had the antibody test and you have the antibodies, do you need to continue to self-isolate?
Yes, 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 and yes.
Okay.
At least distance, socially distance.
Okay.
Make sure you're wearing the mask. Make sure you still keep the 6 feet out. Make sure that you do stay home to some degree. It's important that we still think cognizantly about this. We have to think about it, and we have to look to the experts to be able to say, when is it a safer time? But we have to look at everything. I mean, there's so many factors, as I said, but the antibody test will not tell you that you're cured and you're safe. It's just kind of like influenza. You can catch influenza again. The antibodies only last so long. Chickenpox, you really can't catch again. You can, if you just take the vaccine, you may get a small type of chickenpox. If you catch chickenpox once, you won't again. Shingles, yes, but not chickenpox. So some viruses are prolonged always, some are not. This we don't know yet.
Okay.
We don't know if it's neutralizing. And so that's the whole thing. It could be, like I said, people getting antibody testing are doing it because it helps them think about whether they had it. I still can't give all the answers to whether that was true neutralizing or not. So that's why I think so many people want to get it. And that's why I'm happy to give the antibody through it and talk to people. We're working 14-hour days to get people through it. And that's important. It's so important. In all my years, this has been the most important part of medicine because of the anxiety.
Wow. Would you comment on the testing that you're doing? So if somebody is interested in that, is the antibody testing, just tell us what the process would be, and are you limiting it to people who are either have underlying symptoms or have underlying health conditions or symptoms, or just tell us a little bit more about what you're doing, please.
What we're doing right now is anybody who wants to get antibody tested, they don't have to be patients of mine. They can either just call through the phone number to our office or email going straight to the our webpage, which is just PV Med Group. I got a, pvmedgroup.com.
Right.
And then that'll get you right onto, there's a section for the coronavirus. So that'll get you on, and it may take to get back with you because we're getting hundreds of calls every day or hundreds of emails. We rather answer through emails rather than people hang on to the phone because there are so many phone calls. It's a longer wait. I mean, we've never seen a volume of phone calls like this, but we're more than happy to help. If the insurance is accepted, which most are, except a couple insurance companies are not, IPA groups are not, it goes to insurance, except for right now the insurance companies are not paying for antibody testing. They may be eventually, so they should be eventually, sooner or later, but I don't know when that's going to be.
Thank you. Tomorrow, by the way, we'll be sending out a link tomorrow, a thank you to all the participants on the call. You'll get a recording of this call, and we'll also include the link to your page. So if somebody's interested in finding out, we can include that link in the email that will go to everyone tomorrow. So thank you for that.
We have doctors, nurse practitioners calling in, talking to each patient, finding out, when they had a problem. Or some patients are getting the antibody testing because their family had, COVID and they want to see if they had it. They were asymptomatic carriers. So we're doing things, in that manner. So that.
Okay, thank you. I'm getting some nice little notes like, thank you, you've been our pediatrician. Thank you so much. So lots of nice comments from people as well. Question from someone whose daughter has COPD. Again, not necessarily asking for medical advice, but just wanted to know how concerned she should be.
Of course, with COPD, there's different classifications from gold 1 up to gold 4. Lower classifications, you're not as higher risk. Higher classifications, you are. But in general, you're a higher risk of catch COVID or coronavirus. You are at a higher risk. So you really have to be careful, and you really have to social distance yourself. That's one of the higher risks.
Okay, got it. Well, we're at 1:58. We're going to do 2 more quick questions before I wrap up. I'm a runner. I like to run and walk outside. Do I need to wear a mask when I'm running?
That's a good question.
Yeah.
That really is a good question. Inside, when you're around people, there's a much higher chance of droplet and aerosolized transmission. And we're not even quite sure about the aerosolized yet, although there may be about 5% transmission through that. Outside, if you're not around people, aerosolized transmission will basically just drop right out and dilute. So if you're running alone, not near anybody at all, mask is not as important, and you may end up hyperventilating or having problems. Although a mask in the cold weather in Palos Verdes in the South Bay probably helps you, and you're not going to get exercise-induced asthma. That's a whole other problem we can talk about for hours. But in terms of outside, but the problem is that we have some people that are not observing social distancing and will come right up against you and right near you. You just have to be careful of that and careful of other people around you. So I probably still wear a mask.
That's thank you so much for that. And then the last question was regarding, you talked a lot about some of the questions we should ask when we go in if we get tests somewhere. Do we need to be concerned about where a particular test is manufactured? Somebody was concerned, the question was, they were concerned that the test that was being used was manufactured in China. Do we need to be concerned about that?
I think that's an excellent question.
Okay.
I kind of always smile at that because if you look at where most of your medications are manufactured in Korea, China, in everywhere else except the United States, other than the biologics.
Yeah.
No, not really, because most of the tests were initially created and tested in China and Korea, because that's where it was first. And so that's how everything was tested. So the antigen, all the test is, by the way, is a strip of paper, methylcellulose paper, with antigen put on top of it, antigen for the SARS-CoV-2. So it's spread evenly over it. And then it's put inside a container with 2 wells, and then you drop it, and then you put a solution in it and watch it move up. And that's how all these tests are done, whether it's strep, flu, SARS-CoV-2. And so they're all the same, made basically at the similar type of places, and then distributed everywhere else, and then validated. So basically, I say no, and I say I want data. Give me the data.
Yep.
Ask the doctor for the data. And that's what I'm all about, as a data man. I publish papers from New England Journal to Lancet to everything else, and we can't publish unless we have data. And so that's what you want to see, is hardcore data. Wow. And you also, like I said, you want to see that they do positive controls. Those are they're very important.
Thank you for that. That's great. And we are so fortunate to have an expert of your caliber and experience, again, Palos Verdes Medical Group and Peninsula Research Associates right here in our community. That is amazing. So thank you so very much, Dr. Sher, for bringing both the patient side and the research side to us today. I want to thank all of you. Remember to, if you're chamber members, please be watching your inbox. We are sending out information almost on a daily basis with resources and links and telebriefings and sessions like this. Follow us on social media. Check out our website. We have a special COVID page now with resource links, as well as chamber member news, talking about who's open, what you're doing, things like that. We invite you to join us next Thursday at 1 o'clock. We're going to switch it up a little bit. Instead of having a speaker, we're going to combine our weekly series with our monthly networking lunch. And so the speakers are going to be chamber members. We want you to share your stories about what you are doing to keep your business going, your creativity, how you've reinvented yourself, and you will learn from each other. So we're excited about that. And then the following week on Wednesday, May 6th in the morning, we'll be having virtually our regular monthly breakfast series, and it will be at 8 o'clock in the morning. And we have a speaker from the Small Business Development Center, which is part of the U.S. Small Business Administration, who will be talking to us again about the loans that we hope will be a new infusion of loans will be approved by Congress tomorrow, as well as other resources for small businesses. If you're on this call and you're not a chamber member, we invite you to consider joining us. And for those of us who are members on this call, which is predominantly almost all of you, thank you for being a member. Let us know what you need, and let us know how we can help you. We're committed to supporting our businesses and the community throughout this entire situation. So again, thank you so much, Tony Self, Harcourt's Hunter Mason Realty, and thank you, Dr. Sher, Palos Verdes Medical Group and Peninsula Research Associates.
Thank you.
We wish you all a good afternoon and stay well. Thank you.